My name is Josh Wynn. I'm the program coordinator for Buckeye Wellness. I want to thank you guys. Happy Friday. We have a great lunch and learn for you. But before we get to that, just a couple upcoming announcements from our office. We have the Family Wellness Expo on August 10th over at the RPAC. So if you haven't registered or pre-registered for the event, it's a free event for your families getting ready for the new school year. You can visit go.osu.edu/Family Wellness Expo. Has anyone ever been to that? Great. Yeah, it's a good event. Brutus will be there. Kids love that. My daughter loves it. It's a good time. We also have the summer faculty and staff dodgeball tournament on August 14th over at the RPAC. Very competitive, very fun. So registration ends August 9th. The event is on August 14th over at the RPAC. So visit go.osu.edu/FS dodgeball for registration. And then the last, we are starting our farmers market series starting next month. So our first one will be at Ackerman on August 23rd in that picnic area. And then we'll have another one in September on September 13th in the Rhodes Plaza. So if you would like to get some free or some fresh fruits and vegetables, see you then. For today's presentation, we'll have about 10 to 15 minutes towards the end for Q&A. So if you can hold that to your questions then, it'd be great. If you're tuning in through the webinar, please email me, winn.50@osu.edu, and I will get those questions answered for you. Today's presentation is titled Promoting Healthier Skin in 2019 with Dr. Carr. He's a board-certified dermatologist and associate professor in the Division of Dermatology, as well as the director of micrographic surgery in the Dermatologic Oncology Fellowship Program at the Wexner Medical Center. Did I get that right? Yes, very long. So please help me welcome Dr. Carr.
Perfect. All right, is that working well? Everyone hear me good? All right. Make sure this goes. All right, it was a much more fancy name than he gave my talk. I'm just going to label it skin cancer. So I've been here about 8 years, and I do primarily Mohs surgery, which you may or may not have heard of. We're not going to talk about it a lot today, and cutaneous oncology, fancy way of saying skin cancer. How many in this room sort of either have had or know somebody that's had skin cancer? Right, so it's very common, and that's what we'll sort of talk about as we're going through the talk here. So hopefully you'll learn a little bit. If you have questions that you're burning to ask, you can ask right in the middle. I'm fine with that, so no big deal. So I thought I'd start off sort of talking a little bit about the most common question. I deal with cancer. That's all I deal with. I don't do anything else. So I don't do general dermatology. So this is sort of what I do. And the most common question when someone comes in and they've been recently diagnosed with skin cancer, probably as is the same question as when someone is diagnosed with any other type of cancer, is why did I get this? What risk factors sort of led me to be the person that has the skin cancer and is now sitting in front of you? So these are the two sort of big ones in the room, and the ones I always refer to. There is a litany of other risk factors, and we'll talk about a few of them in the talk, but these are sort of the big ones that we always talk about a lot. The first one is genetics, and so I'm going to be a little bit blanket statement-y here and just sort of say with most skin cancers, genetics play a really big role in whether you get that or not. So whether your parents, your grandparents, your great-grandparents had a skin cancer definitely affects your risk for having skin cancer. Now that's different for different types. So when we talk about melanoma or basal cell or squamous cell, which we'll talk about in this talk, it's a little bit different for each one. But I think the sort of theme throughout them all is if you have first-degree relatives with a history of skin cancer, it does increase your risk a little bit. Now, the other story about genetics that's very interesting, that's just sort of starting to be told in skin cancer, is how the exact genetic makeup of your tumor affects that actual tumor. So we know this a lot more in other areas that have maybe a little bit more funding, such as breast cancer. So in breast cancer, genetics affects sort of the way we look at the tumors. It's a word called prognostication. So how bad that tumor may be down the road, we look at the genetic makeup of the tumor. Also, the way that you treat that tumor in breast cancer is in a big way determined by the genetics of the tumor, what genes make up that tumor. And we're starting to get there with skin cancer. The first one we're getting there with is melanoma. So where we're using genetic tests now to sort of tell us with moles and with melanoma, sort of if they can give us a better picture of should we be worried about this spot down the road. And my particular area of interest, which is squamous cell, high-risk squamous cell skin cancer, we're using this sort of genetic makeup to help us prognosticate or look at that tumor and sort of say, hey, this one may be a little bit of a bad actor down the road. Therapeutics is sort of coming in skin cancer as it pertains to genetics, but we're not quite there yet. The other big sort of issue is the sun. And this is what everyone hears and sort of pounded into you over and over and over again, is sort of the risk of sun. And the interesting thing here is that this is a modifiable risk factor. So if you think about genetics, there's not a whole lot you can do about the genes you've been given. But there is something that you can do about the sun exposure that you have. And we'll talk about this. We're going to talk about this right up front, sort of, what about sun exposure increases your risk and how might you want to modify your behavior. So that's where we're going to really sort of start the talk with is sun protection. So when you hear about the sun, they don't talk about the sun. They talk about ultraviolet radiation. So in a very simple way, what in the world is ultraviolet radiation? It's a type of light, okay? So you can sort of see on the spectrum, we're not going to worry about like nanometers and wavelengths, but you can sort of see the colors of the rainbow there. So that's the visible light spectrum. And UV light is right before that. So it's just a different wavelength of light, but it's a type of light. And you'll see that there are three kinds of UV: UVA, UVB, and UVC. And most people, or people that are sort of attuned to this, have heard of UVA and UVB, because if you look at your sunscreens and it says broad spectrum, you see UVA and UVB, but you don't see UVC. And the reason you don't see that is the ozone takes it out, so it really doesn't hit the ground. So that's why when we talk about UV light, we primarily talk about UVA and UVB. One sort of just little side note is that we're going to talk a lot about sun-safe kind of behaviors. And one thing that you do have to think about is sort of even when you're inside, you can get UV light. So glass can block some. And to our dermatology residents, we always say glass blocks B. So UVB gets blocked by glass. But UVA can go right through it. So whether you're in your car or whether you're in an office and light's streaming on you, you're still getting some UV. And both UVA and UVB haven't been implicated in skin cancer. So of course in my car I have like tint on my windows and like a UV filter on the front because I'm obsessive. All right, so why protect yourself? All right, there's a lot of reasons to protect yourself, but let's talk about some of them. So the first one, it looks like the pictures probably won't come great up here, unfortunately, but that's okay. So the first thing is you can burn. So this is an acute problem. This isn't a long-term problem, but it hurts. It's not fun. Anyone that's had a burn does not like this. Most skin tones can burn, except for really, really dark. It's very, very hard to. But most skin tones can burn. And obviously, this is an acute problem, not fun to go through. What are some other things? Well, a lot of the things that we talk about with aging. So when we talk about sort of looking a little older, there's a lot of factors in there. But with regard to the skin, a lot of it is solar aging, solar induced, sun induced. And so what you can see here on the chest of this female is that below where she wears her bra on the upper breast, the skin looks pretty good. It's got a nice texture. It's got a sort of a monotonous pigment. It's all sort of white right there. It's good looking. And then above that, you can sort of see there are some changes here. So it's a little bit dark, a little bit light, maybe the texture is a little bit more sort of firm. And so a lot of these changes, you can see sort of where she was protected versus where she wasn't. So this is another reason to protect yourself. The big reason, or what I like to think is the big reason, though everybody has their own reasons for doing things, is skin cancer. And that's what we're going to talk about a lot today, is sort of UV's role in skin cancer. And on the upper left is the most common type of cancer, period, which is basal cell carcinoma. On the upper right is a squamous cell carcinoma, and the lower picture is of a melanoma. So let's talk a little bit about sun protection. And we'll talk about this before we get back to talking about skin cancer. So there are two main parts of sun protection that I really think about and that I talk a lot about with my patients. And the first thing, sun smart behaviors, and the second thing is sunscreen. And when we get to sunscreen, if you like are one of those people that read Facebook all the time and are always picking stuff up, you may have seen some really interesting stuff on sunscreen in the last 1 to 2 years. There's been some controversies. We'll talk about one of the controversies. But if anyone has any questions about some of the others, we can talk about them later too. But let's talk about sun smart behaviors. So I do this a lot, and I promote this a lot to my patients. So I only see skin cancer, and I have 1/2 day of clinic every other week in which I see transplant patients and immunosuppressed patients. And the reason why I see these patients is because they're at a higher risk for skin cancer that we'll talk about later. So my patients tend to be very high risk. And we talk a lot about sun protection outside of sunscreen. We talk a lot about sunscreen too. But I think that this is very important. The first thing I say to everybody, because they're like, does this mean I shouldn't golf? Or do I have to quit cycling? And things like that. And the answer is absolutely not. Absolutely not. We don't go through all this. We don't treat you. We don't go through all this medical care to tell you to live inside and be a hermit. That's ridiculous. We do all this so you can live your life and have a great time. And so I think that doing some of these things, limiting your sun exposure between 11 and 2, to limit it, to be smart about it. If you know you're going to be outside, to make sure that you're really protected during those times. To seek shade whenever possible. I go to the extent of if I'm walking down the street, and I'm never walking in the middle of the day because I'm always working, so it's always in the morning or at night when the sun is at a tangent, I always find the shady side of the street, and I walk down that. My partner knows if we're walking down the street and one is shady and one is not, we are crossing the road to get to the shady side. So seeking shade, I'm not really modifying my behavior except for moving to the other side of the street. And then protective clothing. You'll also notice if I'm ever walking down the street, I have a big hat on. And this big hat can really protect my face, can protect my neck. I have sleeves on, so I can wear my short sleeve shirts in the summer. And I put on, it's called a solar sleeve. If you go anywhere onto any online marketplace and put in solar sleeve, these are great ways to protect your arms while you can still wear your short sleeve shirts in the summer and you just take it off at the end. There's a lot of this clothing out there, and there are actually manufacturers that deal specifically just with sun protective clothing that can really help you out. The next thing we'll talk about is sunblock. So sunblock is a really long story, and I'm going to make it just really short. So if you have any questions, you can let me know. So these are sort of some of these are a little bit old and a little bit outdated at this point, actually. So the first thing I still usually tell my patients is that we want an effective block on your skin. And to get that effective block, we need at least a functional SPF of 30. And I put an adjective before SPF, a functional SPF. I need the actual 30 SPF on your skin. Now, to get to a 30 SPF is a little bit more of a long road than you think it is. It's not just picking up a bottle of SPF 30 and putting it on your skin. The reason is Consumer Reports did a report a couple years ago, and they looked at all these bottles of sunscreen. So all sort of the common bottles that you'll find CVS or Walgreens or wherever, and they tested them. And they tested the 30s, they tested the 50s, they tested the 15s, and do you think that they all came back at the number that they're supposed to be at? No way. So most of them, the vast majority, were well below the number printed on the label. And so it's one of these things that to get a functional 30, you sort of got to be at a 50 on the label to really get that level on your skin. And there's actually new data that's just coming out within this past year that really does show that higher numbers are more effective. So I think sort of at a minimum, we should be wearing a 50, a bottle that says 50. But the higher that number, the better, which is different than the advice that I was giving a year ago. A year ago, I said, makes no difference. But now we have some data that shows that these little percentages right at the top do make a difference. It needs to be applied very commonly. So the one thing that breaks down sunscreen, can anyone guess what breaks down sunscreen? Sun, if someone said sun. Sun breaks down sunscreen. What the heck? UV breaks down sunscreen So when you're out in the sun with sunscreen on, it becomes less and less effective over time. And people said water too, and that is definitely a factor that it washes off as well. But sun is sort of the big one. It needs to be reapplied every 2 to 3 hours, which is a lot if you're outside. But to get the really effective sort of nature, so a lot of people say, gosh, I put that on. I put the 50, I put the 100 on, and they still are really tan. And they probably put it on once, and then maybe 5 hours later put a little bit more on, that kind of stuff. It's a pretty common, pretty frequent that you have to put it on to really get the effective sunscreen. You got to get it on before activity so you allow it time to get into the skin, about 30 minutes. Now there are 2 different types of sunscreen, physical and chemical blockers. And we're going to talk about these a little bit more in the next slide with the controversy. But chemical blockers, what they do, to be very, very succinct about it, is they take UV light, they absorb it, and they change it. And they change it so it really doesn't harm you. That's a chemical blocker. A physical blocker reflects the light off of your skin. The physical blockers are titanium and zinc. There's only 2 of them. They are big molecules. Okay, that's how they're able to reflect the light. They're the ones that go on a little bit light or white. So if you've ever noticed you put on a sunscreen, it feels or looks a little bit white, it probably has titanium or zinc if you look on the back of it. So the lifeguards with the white noses, that was titanium and zinc that they were using. The chemical blockers, people like them a little bit more because they go on clear. So they don't go on with that kind of whitish kind of tint to them. But we'll talk a little bit more about them in a second. I did want to make one sort of note about SPF and absorption. So when I said when you get above 50, you get these little tiny increments. This is what I'm talking about. So a lot of people think that like 30 is twice as good as 15, or like 60 would be twice as good as 30. That is not the case. So this is a completely different scale that they use for sunscreen, which makes it very difficult for consumers to know what the heck you're looking at when you're looking at a sunscreen. When you're up to a 30, you're almost at 97% blocked rays. Okay? At 50, you're at 98%. You can see how tiny these get. And by 100, you're like 98 point something percent. So though the number is wildly increasing, the amount of difference of block that you're getting is pretty small. Okay? And that's why historically I was saying, you know, as long as you get up to a functional 30, we're good. But like I said, there's some new data coming out that shows that perhaps these higher numbers may help out a little bit. For me, I make sure I wear a 50. You know, when more and more data comes out that's very conclusive, I may change my behavior. But I think as long as you have that 50 on, you're good. So these are some of the guidelines. These are the AAD, so the American Academy of Dermatology guidelines. And this is what they want you to use. So if it's labeled broad spectrum, so on the label, to get that word broad spectrum, it has to cover UVA and UVB, and it has to be over a 15, or you can't put it on the label. So if it covers UVA and UVB and it's like SPF of 15, or sorry, of like 8, you can't put broad spectrum on the label. So if you see broad spectrum, you know you're getting a decent product, though probably not quite what we want. You can no longer put waterproof, sweatproof, or sunblock on the label, because in reality, it is not a block. Part of the sun still gets through, and they are not waterproof and sweatproof. They just may be a little bit more resistant to these things. So you have to use the word water resistant instead of waterproof. Just a little bit more truth in labeling. The last point about this I'm going to make is that shot glass at the bottom. So enough to fill that shot glass. So if you think of a shot glass and you fill it with sunscreen, is a lot of sunscreen. That is enough for the normal adult body in a swimsuit. So it is a lot of sunscreen that you need to put on. If you're putting it on, you're just sort of lightly rubbing it in, it's probably not enough. It should be, yeah.
What about spray?
So spray, actually a couple years ago, they were thinking about, there was a proposal in front of the FDA to take spray off the market. And the reason is people don't use enough spray. So when they tested it with actual users, people were never putting enough spray on because, you know, I've seen it. My sister's got 3 kids, whoosh, whoosh, and they're done because they're like, sweet, oh my God, like I could barely get that on the kid as they're wiggling around. And you just don't use enough of it. So that was the big problem. Also, there were concerns about inhalation of it. the potential fire capacity of it, just sort of near an open flame. A bottle has exploded before. And on windy days, actually getting it onto the skin. All of these were concerns. Of course, the sunscreen manufacturers had a fit because they're very, very popular. So I think using a spray sunscreen is okay, but you need to make sure that that nozzle is very close to the skin, that it's getting on the skin, and that is like sopping wet. So it should be like sopping wet when you're rubbing it in. And then it's fine. I use spray sometime too. I think it's just using it correctly is very difficult, which is why there was this controversy a couple years ago. But it's obviously still on market. Yeah. Okay, so there have been a couple controversies lately. First, reefs. Second, on systemic uptake of sunscreens. So again, if you're like a Facebook person and always going through, you may have seen this. So this is the most recent controversy. And there was a study that came out, it was probably only 2 months ago at this point, in something called JAMA Dermatology, one of our main journals in dermatology. And it was asking the question, is there systemic uptake of sunscreen? So what they did were they treated a group of patients, probably like 20 patients, and they put 4 different, so like one patient would use one sunscreen, another would use another, and they followed recommendations. How much to put it on and how many times per day if they were out in the sun. And they serially tested their blood to see if there was an uptake of the sunscreen in the blood. And this had actually never been done before, which is very surprising. But nonetheless, they saw that it was over the threshold of where the FDA says, you know, you can be and not have to test further, way over the threshold. And so there was a huge firestorm after this. You know, people were saying, should we not use sunscreens? Should we be done? You know, all this kind of stuff. Now, these were on chemical blockers, not physical. So if you have read that, if you haven't, I think it's important to sort of be aware of it. I think the current recommendation is we just know that it's taken up into the blood. We have no idea what that means. We have no idea. And honestly, there needs to be more studying done before we'll know. This is going to be years before we know. We know that skin cancer is hugely common, and it is increasing in frequency. And so I think the standard recommendation remains sun protection, use sunscreen. If you want to go to the nth extent, use chemical sunscreen, zinc and titanium. I still use physical sunscreens as well. But this controversy is out there, so you may come across this in just the lay press. This is the New York Times, where this article ran, and I saw a lot of other articles on it. Any questions about sunscreen? Because we're going to move to skin cancer next. Yeah. Yeah, these are all more for the way that the product goes on and then what the final SPF rating is. So I would say instead of worrying about percentages, because you'll sometimes see like titanium 6% or titanium 11%, I would pay attention to what the actual sunscreen is and then the SPF number, because it gets very complicated if you pay attention to the percentages. Yeah, it's a good question. So sunscreen and makeup, this is a very common question that I get. And my general take is this. If you put enough makeup on to get this SPF factor that you want to get out of that, which is usually low anyways, it's not very high. They're not having like 50s in makeup very commonly. It's going to look a bit garish. It's going to look a bit clowny because you'd have to put so much on. So my general recommendation is do not rely on the SPF rating of makeup for your sunscreen. Apply the sunscreen first, let that absorb, then apply the makeup afterwards. Yep. I'm sorry? Are you meaning like a makeup kind of powder? Yeah, so I mean, that is a good question. I am not, I'm not going to lie to you. I'm not as familiar with these. I don't recommend them, and so I don't really know the answer to that question. So I will just say that. Sorry. Yeah. Oh, you're fine. Go ahead. Yes. go with the expiration date on the back of the bottle. It probably goes well beyond that, but it's one of those things. If your sunscreen is expiring, you're not using it enough. So let that be a warning. I need to use this more. But I would just go with that date, though it's been tested to go further, but just go with the date. It's easiest. Yeah. What? This can be relatively effective, depending on how much moisturizer you put on. You know, it's the same kind of thing. If you're putting on just this thin, thin film of moisturizer, oh, do we need to? Oh, okay, okay. We need the microphone, is that? Okay, so we'll make sure we pass the microphone around after. The question was, for those that didn't hear, what about the SPF in moisturizer? It's the same as putting on a sunscreen. So if you get a sunscreen and you put a little pea-sized amount on your finger and you put that over your face, it's not going to be enough. It's not going to be effective enough. It needs to be where you put enough on that you're sort of having to actually massage it in. Again, that shot glass is for your whole body, but still it should be a bit of work to get the sunscreen in. But it's absolutely appropriate to use a facial moisturizer as a sunscreen. It's just the vehicle that's different on the facial moisturizer. So I think that's fine.
I had a question about how much sun, like 20 minutes a day, do you have to have any sunscreen on to get the vitamin D, or?
Yeah, so, you know, I think vitamin D is really only an issue on people that are very, very strict. And honestly, it's a bigger issue the darker skin tone that you have. So if we take sort of an African American and someone with Irish descent, it's the African American person that's going to have a little bit more problem because of the pigment in the skin of getting enough sun for vitamin D. But if you have that Irish person with very light skin that is very, very good with sun protection, then it's probably reasonable to have your vitamin D levels checked. The standard from the academy is that you shouldn't use sun for vitamin D, that you can easily get your vitamin D up high enough with supplementation. So I honestly take a vitamin D supplement. So you can supplement to a completely normal level of vitamin D. So generally speaking, most people do not recommend that you go outside to get your vitamin D.
I just have a general question for you. What's your opinion on those harmful chemicals, like, I might butcher it, but like oxybenzone or something they put in those sunscreens, and there's probably 2 other ones that they say to avoid in it.
Mm-hmm.
In sunscreen, like, is
Well,
it really, truly?
You may be talking about, so the FDA came out recently with some sort of a redo of what they consider grace and non-grace. So generally recognized as safe and effective is what the FDA says. And so the FDA is coming to tell you, we think that this is safe and effective, we think this isn't, and we have no idea in the middle. So there were 2 sunscreens that were determined to be non-grace, so not safe and effective. These you will not find on the market. So you'll hear them all the time, and I see them printed all the time. They are not on market. There is the ones that are considered grace, meaning they're safe and effective, are zinc and titanium, okay? Generally recognized as safe and effective. Everything else is in the middle ground, is in the gray zone from the FDA. And that is all of the current chemical blockers on market are sort of in this gray zone right now, where we don't really have enough to say that they are not grace, but we don't have enough to say that they are. They're sort of in the gray zone where we need more studies.
I was told that if you keep your sunscreen cool, like in the fridge or in your cooler, that it works better.
I have no idea about that. I hadn't heard that one. Had you heard that that's more for prolonging the product or
That's
more
what they
effective?
said. It lasted longer because the heat broke down
Okay,
the
that's
chemical.
possible. That's
and
possible.
it feels better when you put it on because it's cold.
Yeah. Okay. I'm sure that's true. I'm not positive about that. There might be some papers out, but I haven't seen them. All right. We'll do one more, and then we'll go to the skin cancer. Oh, I think he's going to bring the microphone just so the people in the web can hear.
So can you really avoid the systemic absorption with the non-nano physical blockers? Is
With-
that
Right. So she
pretty-
brings up another point that I hadn't quite brought up yet.
sorry?
So with physical blockers, so titanium and zinc, she just sort of said a word, I don't know if you all heard it, nano, so a nanoparticle. So if you have a normal zinc or titanium and you're buying it for like 10 bucks or 15 bucks, it's a non-nano product. So we really don't think that those have any uptake into your body. They're very big molecules, and so they sort of sit on top of the skin. There are these products called nanoparticles. So if you have a titanium or a zinc product and that product is 30 to 40 to 50 or up dollars, it is probably a nano product, which means it goes on clearer. It's not as white because the particles are smaller. And there are concerns from some groups. The EWG, it's this environmental work group that really sort of says it's not good until it's proven it's good. They have some concerns about nanoparticles. None of those studies have shown any issues to date, but it is a concern that's out in the lay press, and I don't think we have enough data one way or another on nanoparticles. But the non-nano, yes, we have some data that those are not systemically absorbed. The white ones. Yeah. Okay, so let's go ahead and move on to the next one. I'm just going to sort of see where we are on time here. All right, we're doing well. All right, so we took a long time with sunscreen. That's okay. It's what everyone usually wants to hear about. All right, so we'll talk a little bit about skin cancer maybe for the next 10 minutes or so, and then if we have some more questions, we can do those as well. So I'll try to move a little bit more briskly through this. So skin cancer rates are increasing, okay, of all types of skin cancer. The most common ones are basal cell carcinoma, squamous cell carcinoma, and melanoma. I'm just going to make one note that there's a ton of other skin cancer, a lot of it. But these are the ones that make up 99% right here. So there's lots of other different names. Oops. This guy back on. So there's lots of other different names of skin cancer out there, but they make up this tiny little fraction. So we're not going to really talk about them. Those are more for like medical meetings or if someone actually has it. Then we go over that. So let's talk a little bit about basal cell carcinoma first. So this is a picture of a basal cell carcinoma. My usual thing for patients when we're talking about squamous cell or basal cell is the same kind of stuff. As they get more of these, and particularly my transplant patients get a lot, so they get pretty good at finding them. But people always want to know, what do I look for? What do I look for? You know, what about that should alarm me? And my general rule of thumb is if you're getting a new lesion that is lasting more than 4 weeks or is symptomatic, bleeding, painful, someone needs to look at that and make sure that it's not anything that we need to worry about. Everyone's going to get bug bites, infected hair follicles, acne bumps, all these things. These should resolve or at least be improving by about 4 weeks. But if you see something at 4 weeks that's getting more noticeable rather than less noticeable, it's probably a reasonable thing to get checked out. Everyone in this room is not a dermatologist. That's what they're there for. So if you're seeing that kind of spot, that's when you get in to see the dermatologist. And we'll talk about some more particulars about basal, just more for your information. Another example. Now the thing with basal cells, this is the usual. This is what we normally get. And people always say, so one of my sort of talking points when someone comes in for basal cell, I say pretty much the same thing to everyone. You learn to have scripts when you're a doctor. You say the same thing. I know what I'm telling somebody. But my script for basal cell is, this is the most common type of skin cancer. This is a skin cancer that is only locally on the skin. It does not metastasize or go to other areas of the body except for in extreme circumstances. So this is a local skin problem. The reason why we are taking care of it today is because if you don't take care of it and you give it enough time, meaning several years, it will keep on getting bigger and it can be locally destructive. Okay? That's my talk. And that's why. So this has probably been there for 20, 30 years. There's obviously lots of other things going on with these patients that let them go to this extent. But this is what can happen. They just keep on going. So basal cell is one of those I put it in the sort of category of inconvenience. It's not fun to have it, but it's more of an inconvenience, and you don't want to let it become a problem, because now it's a problem. And so that's sort of the talk of basal cell. Again, this is the most common type. It's 4 times more common than squamous cell, 20 times more common than melanoma, an estimated 3 million cases a year, and that actually might be a low estimate as far as how many basal cells. Again, if it remains on the skin, it can be locally destructive, but it rarely metastasizes. And that word again, metastasize, means go to another area of the body. Some of the risk factors that we've already talked about. So genetics, and genetics are going to play a role in whether you have light hair or eye color, or you have Northern European ancestry, and your inability to tan, and UV light exposure. We also see it a little bit more commonly in men, but we see so many of these. Believe me, we see plenty of women as well. So the clinical presentation, if you want to know a couple more little details about basal cell, at the beginning I gave my sort of really general description of, if you have something over 4 weeks, it's getting bigger or symptomatic, come see a dermatologist. But here are some of the more specific things that you can look for on an actual spot. So if it bleeds easily, the cells of a basal cell don't adhere very well. So even a little knock can make it bleed. And often people will say, I knocked my head onto something in the garage, and then this basal cell came. And that's not actually what happened. What happened is you had the basal cell for a while, and then you knocked your head. It started bleeding because it was a basal cell, and now you're here in front of me. So they just bleed very easily. Lesions that don't heal, so something that just sort of persists. And then this last one, irregular blood vessels in or around the lesion. And I'll show you what I mean by that in the next picture. So this is a big example of a basal cell. Sorry, again, it doesn't seem like it's transmitting too well. But with this basal cell, obviously, if you saw that on your skin, you'd say, okay, I got to get that looked at. But this is probably a basal cell that's been there for 2 years. Okay? They don't start out looking quite this obvious. They start out looking very innocuous. But these, let's see, so these are the little blood vessels. You can sort of see them at the side, and there'll be a lot of blood vessels. As you look more and more, you'll see more blood vessels. And we actually use this as clinicians as a very big clue on whether we're worried about a basal cell or not. Another thing, again, this is more just if you're a little bit nerdy like I am, you can notice here it's got like we call it, it's a great word, a pearly luminescence. Wonderful description. But it's this sort of pearliness that you see on there. It almost flashes light back at you just from normal light in the room. Another thing that is common with basal cell. There are a lot of treatments out there. So this list is non-inclusive. There's way more than this. So there's a lot of available treatments. I am a Mohs micrographic surgeon. And so I deal with more complicated basal cells, usually on the head and neck, eyelids, nose, lips, stuff. That's what I do. So we use that for more complicated type of tumors. But there's a lot of other choices here. And the point of this list is not to talk about each of the choices, but to sort of say, to realize how many are out there. And you need to make sure that you're with the right person when you're talking about how to take care of if you were to have a basal cell. And so this is where I think having the right training, making sure you're seeing a board-certified dermatologist is very, very important, because there are a litany of options, and you need to make sure that that person that you're talking to knows all of those options and can determine the right one for you. So some key points here about basal cell. It's the most common. There are multiple risk factors that can lead to basal cell. If you leave it without treatment, and again, on that picture I showed you that was bad, don't get nervous. That's not going to be you. That's if you leave it there for 20 or 30 years. Okay? So, but that's why we take care of them. So we don't let them get to that extent. And there are many different treatment options. And so really making sure that you're at the right person to help you take care if you were to have one or your family member was. The next one we'll talk about just for a few minutes is squamous cell carcinoma. This is the second most common type of skin cancer. And this is actually sort of my area that I'm interested in particular, is high-risk squamous cell. We're not going to talk about high-risk squamous cell. It's complicated, and it's not that common. But nonetheless, approximately 750,000 cases per year. So this is way lower than basal cell, but that's still a lot of skin cancer. So this is still quite a common skin cancer. Most commonly, you see this on sun-exposed areas. So head and neck are the most common. Interestingly, with squamous cell, it can become metastatic. So when I was in residency, one of my sort of attendings, he told me a line that I never forgot, and that is, beware the squamous cell, because this is not basal cell. This is something that can be more aggressive. The way I talk to a patient when they come in with a squamous cell is I say, this is the second most common type of skin cancer. This is one that we consider intermediate risk. By that, I mean if we catch it early, meaning it's small on the skin surface and no other high-risk features underneath the microscope, then the chance of this going anywhere else in you is about 0. However, if we let this spot go and get bigger on the skin surface and get some other high-risk features under the microscope, it can get the potential to go somewhere else in your body. And that's why we're going to take care of it today. That's my usual talk with a squamous cell. So again, you're getting this idea. Just get them when they're early. Just get them when they're early, and we can take care of them. This is an example of a squamous cell. Squamous cells are a little bit harder. They're a little bit harder to get on clinical exam. So basal cells have a very obvious kind of look to them. And once we sort of get used to it, we're pretty good at catching a basal cell. Squamous cells have different faces, and so it's a little bit harder. But I think the same things are true. If you're getting a spot that's not resolving and that's getting worse or symptomatic, it's something that needs to be looked at. And for squamous cell, that's particularly true. So again, another example of a squamous cell, you can tell it's sort of this nodule with what we call keratotic debris on top. So it's this scale crust that you see right in the middle. That's not like dry skin. It is hard as a rock right there. And that's what we mean by keratotic debris. A lot of these will have these really hard places. If any of you have anyone that was a sun worshiper and is now like mid-80s or something like that, feel their arms. And that's what I mean by keratotic. You'll notice it feels hard in places. And these are little pre-skin cancers that they might have on their arms that are super common. Risk factors, they're very similar here. So sun exposure and then genetics, so personal family history of squamous cell. There are some other things on this list, though, that can increase your chance of getting a squamous cell. One is something called a chronic scar. So a scar that's been there for a long time. And we're not talking like you had a surgery, you have a little line scar, and in this scar you're going to get a squamous cell. We're talking about a scar from a lesion that's sort of festering, going back and forth between healing and not healing over a long period of time. Can induce a squamous cell. Chemicals can. Arsenic, which everyone's like, where would I come into contact with arsenic? Well water sometimes can have arsenic in it, and that can increase your risk for getting squamous cell. The wart virus. So we know the wart virus causes some forms of cancer. The most common one that everyone knows about is cervical cancer, but it also plays a role in skin cancer, primarily squamous cell skin cancer, and we're learning more and more about that every day. And then for me, immunosuppression is a huge factor. And just to tell you how bad it is in immunosuppressed patients, if you remember, I said that basal cell is 4 times more common than squamous cell, right? Do you remember me sort of saying that? Basal cell is 4 times more common than squamous cell. In immunosuppressed patients, squamous cell is 4 times more common than basal cell. And it is not that basal cell goes down in immunosuppressed patients. It actually goes up 3-fold. That's how many squamous cells they get. It actually works out to about 65 to 100-fold more in transplant patients. So you take the normal rate and multiply by 65 or 100, and that's the rate in transplant patients. So we actually have transplant clinics to sort of help with this. Tons of options again, and I won't belabor the point. You need to make sure that you're at the right place to take care of that squamous cell, because again, there are a lot of treatment options for squamous cell. We won't get into them in detail. So some key points here. Second most common type of skin cancer, lots of risk factors. Again, if left without treatment, not only can it be locally destructive, but now if you really let this go, it can progress to regional and distant metastasis. And this is uncommon, but it can happen. And again, by metastasis, we mean going to other areas of your body. All right, and the last one, let me just sort of see where we are in time here. Okay, and there's only a couple slides here. Melanoma is like its own talk. So we're just going to give a few slides on melanoma. I wanted to talk a little bit more about sort of sun protection and all that kind of stuff, and basal and squamous cell, because melanoma, a lot of people know a lot about melanoma. So we're going to just say a few words here. Melanoma is the one that you think of with brown spots. So when people are watching moles or things like that, and they think, I think a mole is changing, this is melanoma that we're maybe potentially concerned about. And melanoma is very well known because it's a bad actor. It's a bad type of cancer. It's one of those that if it progresses just a little bit, it can really get out of control and metastasize quite early in its course, which is why melanoma is probably talked about way more than basal or squamous cell, because it can be more dangerous. The incidence here is rising faster than really any form of cancer. We're just seeing a ton of melanoma cases. It's still far below the other types, but it's becoming quite common. And the other thing that's really sort of emotional about melanoma is a lot of times it affects younger people. So if you go to a tumor board and it's a melanoma tumor board, a lot of times you're hearing about people that are in their 20s, 30s, and 40s. And again, you're also hearing about people in their 70s, 80s, and above. But it can affect people that are younger as well. And it is the most common cause of cancer deaths in women 25 to 30. That's just sort of an idea of how aggressive it can be. Individuals born today have a greater than 1 in 80 lifetime of developing melanoma. So that's a pretty high number. And again, if I haven't said it 15 times before, catching it early is key. It's more key here than in any other type of skin cancer. Yeah. People have all sorts of potential reasons why it's higher, and the list is long. So the list goes, it could be sun exposure patterns over the last 50 to 70 years, and the increase in sort of tanning and things like that is an idea. Iatrogenic causes, by iatrogenic I mean what we as the healthcare facilities do to patients, meaning immunosuppress them and things like that. Can that play a role? Further detection, because people are more aware of it now, people are going to dermatologists, is potentially a role. Overcall, meaning when you send it to a pathologist that they are doing some COA, so covering your backside, and maybe overcalling things just a little bit. The list goes on and on and on. And there are a lot of studies that are trying to elucidate why we're seeing this huge increase right now. And we don't have an answer yet as to why we're seeing it, but the list is long. So these are the things that you want to know about melanoma. And the ABCDs are probably the best thing that I can teach you today about melanoma. And so ABCDs, you may have heard about this before. A is for asymmetry, which means if you put a line in that lesion, does one half sort of look like the other half? Generally speaking, not like a perfect, but generally speaking, does it look like the other half? And if you take this example over here, there is no way you can draw a line and make one half look like the other half. This is a crazy lesion over here anyways, but it's very, obvious. Border. Is the border nice and clear and obvious? Or is it multiply colored and sort of blurred and difficult to tell? Color. Does it have specific colors, such as red, white, gray, or black? Or is that color changing a little bit? And finally, diameter. A mole that's greater than 6 millimeters, about the size of a pencil head eraser. And the real thing that's not on here is the E, A, B, C, D, E. So E is evolution, meaning is it changing on one of these metrics, okay? Because some people may say, I have a mole right here. It's bigger than a pencil head eraser, and I've had it since I was a kid. And that's okay. That's called a congenital mole, and they can be a little bit larger, but they don't tend to change. They grow with the child, and then they sort of stay similar. So it's don't say, oh gosh, I have one that's a little bit bigger than a pencil head eraser. It really comes down to change within the mole. If you're seeing it become more asymmetric, the border become irregular, the color change, or the diameter get bigger. These are the things that we're looking for. And if you do have a lot of moles, you should probably be following with a dermatologist so someone can help you watch your moles. This is just an example of a melanoma of a superficial spreading, which is a specific type of melanoma. But you can see on our ABCDE, this is not going along with very many of our ABCDE. It's asymmetric. The border is irregular. There's lots of colors. And the diameter, it's hard to tell because it's a close-up picture, but it's big. and another very bad looking melanoma. Melanomas can be anywhere. So that's the last sort of point I'm going to make on that. Melanomas can be anywhere on your body. The darker the pigment of your skin, the more likely it is to be on hands and under nails. Okay? So we see this in darker skin tones, really from about 3 or 4. So in East Asian populations and African populations, we'll see hands and under nails are more common amongst those populations. So they can be in some pretty different places. So it's one of those things, a total body skin exam, you got to be looking everywhere. I'm not going to talk much about prognosis. This slide is basically showing the prognosis on one marker that we use for melanoma. And we're not going to get too much into detail, but this is sort of the depth of the tumor in the skin. And you can see as that tumor gets deeper, how that prognosis goes down very quickly. And the real point of the slide is, if we catch these early and we catch them when they're thin, they have a much better prognosis. And so again, really looking at yourself, following with a dermatologist, and if there's something that's sort of changing on one of those ABCDs, to make sure someone takes a peek at it. These are in your slide handout. We're not going to go over it because we don't have time, but it's sort of what I do. So if you want to take a little peek at what I do, you can see them in the slides. It's sort of got a lot of pictures. It's really fun. It's really cool. It's a great technique. And I just want to leave you with 2 parting thoughts. So the first one is that skin cancer is extremely common. Those numbers are big. 3 million, 750 million. I mean, these are 750 million, 750,000. These are big numbers. And early detection is the key for it all. If we get these early, we can take them off and we can get rid of that spot. If we miss them for a little while, it can become much more problematic. Sun protection is really pivotal in reducing the risk. It's the thing that we can do other than making sure that you're following with the correct physician to make sure that you decrease your risk, whether that's sun protection, just behaviorally, or with sunscreen. So those are sort of 2 big things. So thanks. Thank you. Any questions?
Any questions? Now is the time.
Yeah.
Here we go.
Questioning tanning beds, that wasn't mentioned.
Yeah. I hate them. They're awful. They're horrible, horrible things. They're awful. Every time I go by on Olentangy River Road and I get that Starbucks, I'm just like, oh, and people are going in. I just want to say, stop. I want to be someone that holds a sign outside, but I'm not going to be that person. So tanning beds definitely are associated with increased risk of skin cancer. You may have heard 5-10 years ago, people could sort of say, you know, we're not really sure, data isn't there. There's some really good studies now that look at tanning bed behavior and look at basal cell, squamous cell, and melanoma and sort of definitively really associate that kind of behavior along with increased risks in that population. The real concern with the tanning bed group is that tanning beds, it's really difficult. They espouse health benefits by going to the tanning bed. So you actually see this in some of their advertising, things that can improve, that we've seen improve. So this can improve your depression in the winter, you'll feel better, you get your vitamin D, all this kind of stuff. And people actually sometimes use this in advertising. But at the end of the day, I think we just know the association between tanning beds and risk for these common types of skin cancer. Uncommon ones, they're too uncommon to really study, but we do know it for these. So yeah, I didn't specifically mention it, but I sort of lump it in with just sun. Yeah. And I do have one amendment. When I said you should do everything that you want to do, that does not include laying out in the sun. Like if that's a thing that someone wants to do, that's probably not the best thing in the world.
Any other questions?
Did you want to bring the... Oh, sorry.
I had melanoma 10 years ago, and I've heard 2 things that concern me.
Mm-hmm.
One is that because I've had it, it's unlikely I'll get it again. But I've also heard the opposite, that I'm more likely.
You are.
Which it literally is 50-50 of what I've read.
Yeah, you clearly are. Yeah, so I'm not sure, where did you read otherwise? So this is one thing that I do tell people. So sometimes we're diagnosing people with some not so great stuff sometimes. And people, as soon as that happens, very rightfully so, start looking online. And I think that is fantastic. More information is better information. But more information needs to be good information. And so what I tell people generally is that you need to go to reputable sites. So this needs to be WebMD, eMedicine, Mayo Clinic, names that you recognize. So that, because if you read a blog, or if you read someone where you don't know who that person is, who knows who they are, who knows what their training is, who knows what they really know about that subject. It is very clear, unfortunately, but you're probably following with a dermatologist and being very safe about it, that you do carry an increased risk. And not only do you carry an increased risk for melanoma, but for other types of skin cancer as well. This is new data that comes out in the last couple of years. And I don't think that's too equivocal at this point. So that's what I would just be careful about. You want to make sure that's super reputable, because I love people informing themselves, but you want to make sure that's that right source.
Last question in the back.
If you're concerned about maybe something you see on your skin, is it best to start with your primary care physician or try to get in to see like a dermatologist or something?
I think if your primary care physician is comfortable doing skin exams, there are different primary care physicians out there, that I think that is not an unreasonable place to start if you have a spot. If you already have a dermatologist, that would be where I would go to. But if you already have that relationship and you're like, gosh, I know I can get in there in a week. And unfortunately with dermatologists, it's a little while. Then I might say that is not unreasonable to just go see that. But if you already have that relationship, usually with a dermatologist, you say, I have a new spot, they tend to get you in.